everyone for attending our Lincolnshire Grand Rounds. Our honor guest today is Matt Daniel. He's the lead pediatric ENT consultant in Nottingham University Hospital and the academic lead, and he is really interested in training and educational stuff. He's also one of the European board examiner, and it's a great honor to give us this nice topics, which is really for the trainees or the non-trainee people who would like to go for exams. This is one of the hot topics in the exam, and it's also in your life, so because it's life-threatening. So I'm going to give the mic to Matt.
Thank you very much for that introduction. You make me sound much more important than I really am. I just turn up. But thank you very much for the invitation, and thank you very much everybody who joined us. Feel free to ask questions as we go along. Hopefully there'll be going to be some time at the end, but if anybody has questions, then do ask. I'm working for my other screen in case I'm looking over there. And has my screen moved? Can I check?
Yes, it's moving.
Yeah, perfect. Okay, so I'll be talking about pediatric airway emergencies, and probably the first thing to say is that the differential diagnosis of laryngotracheal obstruction is really very wide, and I think that's partly why it is a difficult topic, because there are so many different pathologies that it can be when somebody presents with airway obstruction. And I've kind of broadly split them into congenital and acquired, and into supraglottic, glottic, and subglottic. And in my talk, I'll really focus on the emergencies, but I'm going to split it down to the age of presentation, because I think the most useful way to think about it in terms of what's the likely diagnosis and what are you going to have to do really would be based on the age presentation. So I'm not going to cover all of the conditions that I've got there, but I've just put that on there just to recognize how complex this is. So I'm going to start a little bit with assessment. So when you see a child that's got airway obstruction and stridor, what are you going to do? Well, as you could expect, the first thing that we're going to do is we're going to take a history. And the history is going to focus on airway, voice and cry, and feeding and exercise. Because if you think that's what do babies do? Babies, they breathe, they cry, and they feed. And, in all the children, we can substitute feeding for activity. So with airway, is it stridor? What kind of stridor do they have? Is it inspiratory or is it biphasic? Do they have breathing problem? Do they have poor exercise tolerance? And in all the children, exercise tolerance might be running around, or how many star jumps can they do? In babies, really, that's all about feeding. And then if they got a hoarse voice, or if they're aphonic, that would suggest that that's a vocal cord problem. And then feeding, and feeding may be that the fact they get out of breath when feeding, so that typically might be what you happen in babies. But you might find that also in older children they might be aspirating, so they're coughing and spluttering when they're feeding, and there might be failure to thrive as well. And often involving pediatricians is useful in trying to assess that failure to thrive. Then in past medical history, have they any perinatal history? Because were there any problems antenatally, for example? Was there anything to suggest that the baby had antenatal airway obstruction, polyhydramnios, for example? Have there been any abnormal antenatal ultrasound? What was the delivery like? Was the delivery traumatic? Did the baby struggle to breathe right in the delivery room? Is this a baby that had issues with the airway right from when they were first born? Or have they had, any trauma? Have they been intubated, maybe on neonatal unit because of prematurity or because of other reasons? And then, of course, comorbidity, because if you have a child that has a number of other associated comorbidities, then that might be something that explains what's going on. The timing of symptom onset is key, and I'm going to talk a little bit more about that. And then you would also look at exacerbating factors. So, for example, is there a position in which they lie? Often children are worse on their back. They might be better on the side, particularly if somebody's got tongue-based related airway obstruction, or feeding might make matters worse. And the symptoms, of course, depend on the severity of the narrowing. And most of you will know that that Poisson's law describes flow through a tube, in general, flow through any tube, and that is relevant to flow of air through a tube, which is the airway. And the key thing really is that the flow is proportional to radius to the power of 4. And that means that a relatively small reduction in the radius will have really quite a big reduction in airflow. And if you look at the kind of neonatal airway typically would be 4 millimeters in diameter, something like that. So if you lose a millimeter of airway narrowing, so you go down to 2 millimeters, that reduces your cross-sectional area by 75%. And resistance increases 16-fold. Whereas if you take your adult airway, if you lose a millimeter of your adult airway, cross-sectional area goes down only by 30% and resistance is only double. So small amount makes a really, really big difference in children. The plus side of that is that if you make the airway smaller by a small amount, that also makes a big difference. Yeah, so that's why, you know, I find pediatric airway really very satisfying, because actually just some very small things that you do actually make really quite a big difference. And then carrying on with assessment, you would then examine the child. So that might be kind of your general examination, particularly if you think that somebody has got any associated symptoms. And you might do a flexible laryngoscopy either through the nose or through the mouth. You might do a rigid airway endoscopy, and that goes by the names of microlaryngoscopy and bronchoscopy, MLB. I think most people in UK use the term MLB. Personally, I don't like it because I don't know anybody who does a microlaryngoscopy. Yeah, so you know the term that I prefer is laryngotracheal bronchoscopy because that is what I do. Yeah, but you know most people in UK call it MLB. And then flexible bronchoscopy can also be useful. And the different ways of examining the child, to me, they're all complementary. So there isn't one right way of doing an airway endoscopy. So, for example, the flexible laryngoscopy is useful because you can examine the nose, you can examine the nasopharynx, oropharynx, and you can kind of see down to the level of the glottis. So flexible laryngoscopy, you know, really useful for that upper airway, and particularly useful for laryngomalacia. Yeah, laryngomalacia is a supraglottic problem. So if you do a flexible laryngoscopy, you can see laryngomalacia, and usually you can see vocal cords as well, but you can't see below. So then we got rigid laryngotracheal bronchoscopy. So, you know, that typically looks at the oropharynx. You can see the supraglottis, the glottis, subglottis, trachea, and the main bronchi as well. If you want to look further down, then flexible bronchoscopy can be useful. And again, flexible bronchoscopy can look at the supraglottis, but then you're able to see beyond right and left main bronchi as well. So the three different investigations, I would say, are complementary. For flexible nasolaryngoscopy, sort of this is the kind of position that normally I would advise that a child should be sat in. So, you know, you get the child sat on a parent's lap, and the parent wraps the child up and gives the child a hug. And then either the parent holds the head, or the parent hugs the child, and the nurse stands behind the patient, and the nurse holds the patient's head. And you can certainly quite easily do this up to the age of about a year or so. I think there's a bit of a debate as to, you know, do you flexiscope all the children? And certainly once they get to close to 1 year or beyond, you'd have to pin them down pretty hard. So, you know, there's a question about, do you really want to be pinning the child down? Maybe when they get to sort of 7 or thereabouts, you know, you can have a game with them. But between a year and sort of 7 years, they're often quite difficult. So some people do pin them down and have a look. You know, personally, I don't. And the reason why I don't is because I always think, how is this going to add? So if I'm doing something that I think is going to change what I'm going to do, then yes, you know, I can see there's value in pinning a child down. If I don't think that my examination is going to make that much difference, then usually I personally would be against pinning the child down. But you know, that's different people have different views. I did my fellowship in Australia, and you know, there children just got pinned down of all ages. Like even like no child ever went to theatre for foreign body nose or foreign body ear removal, because you know, no matter how old you are, you just got pinned down, and people took out your nose foreign body. So there might be kind of a cultural thing there as well. You've got a choice of going through the nose or going through the mouth, and they're both okay. if you need to see the nose, then obviously you're going to go through the nose. If somebody's got stridor, then you might not need to see through the nose. And actually, I personally prefer to go through the mouth, because if I go through the mouth, I often get a really good view of the larynx. When the baby cries, the airways opens and you get a great view, and you can use a standard 4mm telescope, you know, your bog standard chip on the tip scope that you use for, you know, your adult head and neck clinic, and you get a really, really good view with 4mm. You probably struggle to get a 4mm scope through a child's nose. So if you're going to go through the nose, you probably need something smaller. And there are companies that now manufacture disposable scope. I think there's a 1.8mm, something like that, disposable scope that's available. And actually, you know, if you're going to go through the mouth, you can just use the standard 4mm one. If you're somebody who would want to go through the nose, then the disposable ones are really, really useful, because you can get them, and you know, and you can keep them, and if it's something you don't use all the time, you just keep the disposable ones and then you use them as and when. And then diagnostic airway endoscopy or rigid laryngotracheal bronchoscopy, that's typically done with a Hopkins rod lens telescope and a standard anesthetic laryngoscope. And finally, the Stort's ventilating bronchoscope can be used, particularly if a child is struggling to breathe. You know, normally children would be spontaneously breathing. I'm going to come on to the anesthetic side in a second. But if you have somebody who, for whatever reason, is struggling to maintain the saturations, or if you're going to do anything therapeutic like removing a foreign body, then the Stort's ventilating bronchoscope is a really, really useful tool for that. When it comes to anesthesia, you know, I'm not an anaesthetist, but sort of this is kind of how I think, or this is what I might ask for, sort of if somebody was asking, what do I want? So you've got to somehow give induction, and induction can either be intravenous or it can be inhalational. You've got to keep the child asleep, and that can either be intravenous or it can be inhalational, and you've got to give the child some oxygen, and oxygen can be delivered either via, you know, high flow oxygen, such as Thrive or Optiflow, for example, or you can use it with a tube through the nose that sits in the supraglottis, or you can hold a tube in the hand that sits in the supraglottis. But either way, a tube that delivers oxygen supraglottically, or you can deliver oxygen through the ventilating bronchoscope, or if you're doing a flexible bronchoscope, then you can put in a supraglottic airway device or a laryngeal mask airway. Okay, that only really would be for flexible bronchoscopy. Yeah, so you've got to give them, you've got to keep them asleep, you've got to give them oxygen, and you've got to put them to sleep. They're the kind of three different things. And broadly speaking, people tend to fall into two camps. They either give them TIVA, so propofol and remifentanil, to keep them asleep, and that typically would be combined with a high flow oxygen, or you might get people that keep them asleep and oxygenate them inhalational, and that then would be sevoflurane in oxygen. And then that way you hold the tube in the hand and you give them sevoflurane in oxygen. So they kind of tend to be the two broad camps. Yeah, but you've got to put them to sleep, you've got to keep them asleep, and you've got to give them some oxygen. Ideally, you want them spontaneously breathing, and you put some lignocaine onto the vocal cords, because that means that the vocal cords are less sensitive, and that means that the child doesn't have to have such deep plane of anesthesia. And finally, the thing that's really useful for me, particularly when you have somebody that has tongue base airway obstruction or micrognathia, you know, somebody with golden hair, for example, or somebody that's got Pierre-Robin sequence, for example, video-assisted fiber optic intubation is really useful. And that's something that's worth bearing in mind if you do ever find yourself having to intubate somebody that's got a tongue base airway obstruction. You know, hopefully you won't, but if anaesthetists ask for help, you know, that video-assisted fiber optic intubation, that is my go-to tool. And typically what would happen with that is the anaesthetist would use a glide scope or some kind of video device, possibly with a curved blade. So the anaesthetist will use that device to find the vocal cords, and then I would use a flexiscope to then go through. So it's kind of two-person technique. One person has the glide scope or a video laryngoscope, and the second person drives a flexiscope and intubates with a flexiscope. And you know, that for me has revolutionized the kind of the tongue base, really difficult airway obstruction. So, and it's a really, really useful thing to do, not least of which is the fact that you as an ENT surgeon will be well used to driving a flexiscope, because we do it all the time, and the anaesthetist will be well used to using a glide scope because they do it all the time. So it's just a combination. They use the glide scope, you know how to use the flexiscope, and you just combine those two sets of expertise, and that's really useful for anything that's tongue base related. And then sort of finally, in terms of other things that sometimes can be useful, chest x-ray can be useful, a barium swallow can be useful, or a CT angio, CT scan of the trachea. Sleep studies can be useful if you think that somebody's got an issue with airway obstruction, and swallowing assessment, video fluoroscopy or FEES. Sort of some of these, for example, perhaps are a little bit more on the elective side. So any questions so far about sort of assessment before I move on to specific conditions?
Yeah, myself.
Go for it. Yeah.
Do you use the high flow in children, or do you use the nasal intubation, the nasopharyngeal tube?
So I tend to let the anaesthetist decide, because, you know, from my point of view, you know, I mean, this is going to sound awful, but as long as they're asleep, have their RAM, as long as they're asleep and they're alive at the end, you know, I don't mind whatever the anaesthetist wants to do. Yeah. SAD is a supraglottic airway device, like a laryngeal mask airway. There are other versions of LMA. So supraglottic airway device is a generic term. Yeah. So some anaesthetists, typically what I see, anaesthetists will either do TIVA and Thrive or Optiflow, or they're going to do inhalational sevoflurane with oxygen that way. From my point of view, it makes no difference. The two anesthetists that I most work with, they will both use inhalation, and that's fine. But equally, you know, every now and then I work with an anaesthetist that does Thrive or Optiflow and TIVA, and you know, that's fine for me. I don't think that I've got any preference. From my point of view, either's fine. Yeah, as long as the child's asleep and doesn't move and they're still alive at the end of the operation. So I let the anaesthetist decide whatever they want. Yeah.
Great. There is a question. Somebody was asking about the acronym SAD.
Yeah, so SAD stands for supraglottic airway device. Yeah, so that's like a laryngeal mask airway, yeah, or a version of an LMA, supraglottic airway device. Okay, so I've said that the key thing really is going to be how old the child is. You know, that's something that's going to help you identify what the likely thing is. Okay, so in a newborn, stridor that happens right from birth in the delivery room, probably the commonest thing of stridor in the delivery room that requires immediate airway intervention, the commonest cause there probably would be vocal cord motion impairment, yeah, or vocal cord palsy. Yeah, in newborns it is palsy because it is genuinely a neurological thing. Yeah, and in a newborn that presents in the delivery room, usually it's going to be bilateral, and you probably would want to do some imaging because it can be associated with Arnold-Chiari malformation and hydrocephalus. Yeah, majority of them are idiopathic, but some of them might be associated with Arnold-Chiari and hydrocephalus. And if they've got bilateral cord palsy due to hydrocephalus, if they have a VP shunt, then the bilateral vocal cord palsy will resolve, and hopefully ENT won't need to do any intervention. Yeah. So if you diagnose bilateral cord palsy, they need to have imaging. If they have unilateral vocal cord palsy, then often that would be acquired, maybe because they've had mediastinal surgery or neck surgery. So, you know, when I've seen it, typically it would be because somebody's had, you know, heart surgery, for example, or if somebody's had PDA ligation. And I've also seen it in children that have had tracheoesophageal fistulas, particularly high tracheoesophageal fistulas. I've seen it in those as well. And as with assessment, otherwise, you know, typically they're going to have stridor, which is probably going to be inspiratory. Because the vocal cords are going to be in the closed position, their cry is often going to be quite good. Yeah, so the cords are going to be relatively close, so the airway is going to be bad, but the cry is going to be quite good, and they probably will not aspirate. Yeah, because the cords are closed, but they won't be able to breathe. Yeah, so the child won't have enough breath to breathe and feed at the same time. Yeah, so in theory, you might say, well, the cords are relatively close together, so they shouldn't be aspirating in theory, but in practice, the child is going to be so out of breath that they probably will be too out of breath to feed. So they will have respiratory dysphagia. Yeah, they won't have enough breath to feed. So usually they're going to need the nasogastric tube. And in terms of what did you do with the bilateral vocal cord palsy, sort of overall, I probably say about half of them are going to need a tracheostomy and half of them avoid the tracheostomy. The ones that need a tracheostomy are actually easier. Because, you know, because if they're in extremist in the delivery room and they get intubated and you try and extubate them and they fail extubation, then you're just going to do a tracheostomy. And actually they're easy. The ones that are really difficult are the ones that are just managing, because you've then got a really difficult decision about, you know, is this all right? Are they safe to go home? Is everything okay? And actually the ones that you don't do a tracheostomy are much more difficult. And typically then that's an MDT decision. You involve respiratory, you do sleep studies, you involve speech and language therapy, feeding, etc. About half of them recover. Even if they don't recover over time, the airway gets bigger and the problem typically fixes itself. So typically, even if you do a trachea, almost always you get the trachea out. And usually we would say to try and avoid laryngeal surgery until they're at least 2 years of age, because, you know, in the past there might have been a vogue for doing laser chordotomy to try and create extra airway, but we know that over time the child's likely to manage without a tracheostomy if you do end up with a tracheostomy. So you don't really want to do anything in the short term that's going to compromise the airway in the long term. A number of people are doing suture lateralization in infants as well to try and open the airway. So, you know, that's kind of something that's developing over the last few years, and that's probably less invasive than doing laser chordotomy. So there might be more information coming out about that, you know, over time. The other thing also that might happen right in the delivery room would be congenital glottic obstruction. So, you know, here you've got somebody that's got complete laryngeal obstruction. That would not be compatible with life unless you identify antenatally and you do an exit procedure. So an exit procedure would be you deliver the baby's head and maybe one shoulder, and you do a tracheostomy before you take them off placental circulation. But you also get laryngeal webs, and typically laryngeal webs are also associated with a degree of subglottic stenosis, and they present with airway problems as well as voice problems, often from very early on. And laryngeal webs are often associated with velocardiofacial syndrome. So again, for anybody coming up to the exam, you know, that's a really useful one to know. Velocardiofacial syndrome, or I've got it the wrong way around, the VCFS, velocardiofacial syndrome, also known as the George syndrome or catch-22, and it's 22q11.2 deletion. And they have palate problem, cardiac problem, facial abnormality, immunodeficiency, low calcium, learning problems, and speech and feeding problems. Congenital subglottic stenosis, I won't say very much. It does exist, but acquired subglottic stenosis is much more common, and I'm going to talk more about that in a second. So in the delivery room, if they've got stridor, chances are that it's going to be bilateral vocal cord palsy. And wherever you work, you know, if you've got somewhere that's got a maternity department, there's a possibility that, you know, you're going to get called to your neonatal unit because they've had a baby right from the delivery room that's had airway problem. And if it's right in the delivery, vocal cord palsy is probably going to be the commonest thing. The other kind of things that you might also see, you know, you might see somebody that's got Treacher Collins, for example, and again, you know, that might present right in the delivery room, micrognathia, Pieroband sequence, you know, or neck masses. And you would hope that some of this will be diagnosed antenatally. So neck mass, you'd hope that was diagnosed antenatally, and then you can plan the next exit procedure. The children that are micrognathic, typically neonatologists are brilliant at managing them. So actually, in my experience, it's not that common that ENT would be the first port of call for management of micrognathia, because neonatologists are really good at that. So usually what tends to happen is you get called because the baby's born, they're micrognathic, they have CPAP, or they have positioning, you know, or they have side lying, or maybe neonatologists have intubated them, and it's only when, you know, some weeks later they can't get them extubated or they can't feed them. It's only at that stage that they might involve ENT. Yeah? But, you know, in theory, you might get called to the delivery room for somebody that's born with micrognathia as well. And actually, they're really, really difficult because, you know, they're going to be difficult to intubate. So if you do get called to the neonatal room with somebody that's really struggling with the airway, you know they're going to be really difficult to intubate. And that two-person technique, one on the glide scope, one person on the flexiscope, you know, that kind of would be my go-to technique as to how you might intubate a child like this. The other thing is, don't forget about the nose, because of course, you know, airway problems. We talked about vocal cord palsy. We talked about tongue-based obstruction. I'm going upwards, Abdelrahman, rather than downwards. So, but you know, you get those problems as well, yeah. And that might be cranial atresia, which, you know, the history there is going to be classic. You know, airway obstruction. Then the child opens mouth, they cry. As they cry, the breathing's better. Then they stop crying, and then they obstruct. So, you know, normally that history is obvious, and you can't pass a catheter through the nose. But you might also get piriform aperture stenosis, which I've seen more piriform aperture stenosis than cranial atresia. So piriform aperture stenosis is not that rare. Often it coexists with the central midline incisor and holoprosencephaly, which is kind of midline brain abnormalities. So they perhaps don't present as acutely, but they just present a baby that seems to struggle to breathe, yeah, and it seems to have a blocked nose, and kind of they sound very snorty. Okay, and then let's move on to stridor that starts when somebody is a few weeks old. And the commonest thing there, you're going to know this, would be laryngomalacia. Yeah, we do get calls from the neonatal unit with babies with laryngomalacia as well. And it's a bit tricky because I said, you know, the commonest thing if it starts in the delivery room is going to be vocal cord palsy. But laryngomalacia overall is really, really common. And it's often quite difficult because the parents will say, oh, you know, well, it was there from birth. But usually laryngomalacia comes to clinic, yeah. So typically, if I think the bog standard laryngomalacia that I see, you know, they go to the GP and they come to my clinic. So the laryngomalacia where we get referred straight from the neonatal unit immediately, to me that sort of says, okay, this is a bit different than your bog standard laryngomalacia. And either they're much worse, they just have particularly awful laryngomalacia, which means that you don't get called into the delivery room, but maybe, you know, they try and manage the child, you know, over the first week of life, and then a week later, they're still no better. They can't get the child home, and then they phone the ENT. But straight away, that kind of tells me that, you know, if that child's got laryngomalacia, then laryngomalacia is much more severe than might otherwise be. But laryngomalacia is by far the commonest thing. Yeah, the thing to be wary of laryngomalacia is that laryngomalacia is really common, but also it often coexists with other pathology. So just because a child sounds like they've got laryngomalacia and you've done a flexiscope and you found laryngomalacia, don't assume that that's the only thing that's going on. Yeah, because, you know, depending on what kind of studies you read, you might find that, you know, as many as 25% or possibly even more will have second pathology. Yeah, so don't assume that it is laryngomalacia, because often there will be other stuff going on. Yeah. The phone calls from the neonatal units, I think they can be tricky. And the way that I think of those is if they phone and say, this baby's doing absolutely fine, and we're thinking of sending them home, but they're really noisy, can you come and see them? Then normally I probably sort of say, no, you know, just bring them to clinic, because if the baby can go home, they can go home. We'll see them in clinic next week. Yeah, so typically that's kind of what I would say to the team that I work with. I mean, I wouldn't say the registrars have to go to see a baby in neonatal unit, because it's much better than the baby comes to my clinic. If the baby's well and otherwise can go home, it's much better that I see them in my clinic next week rather than the on-call registrar going to see them in the middle of the night and then talking to the on-call consultant. Yeah, but if the baby can't go home, because if the baby's struggling so much that they can't go home, then, you know, you're going to end up doing something for that baby, because they've either got really awful laryngomalacia or they've got something else. Yeah, because as I said, laryngomalacia, typically your typical laryngomalacia, they go home and they come to clinic. Yeah, and they kind of have this folded epiglottis sort of here. You can see it's kind of omega shaped epiglottis, or they have a very tall epiglottis with short hairy epiglottic folds and lots of prolapsing supraretinoid tissue that flops in and out of the airway. Yeah, and often it's useful to describe exactly what you see. I don't think anybody really knows what causes laryngomalacia. We think it's caused by delayed sensory motor integration. And what I mean by that is the sensation of the larynx and the tone of the larynx and how the brain coordinates the sensory information with tone. That pathway doesn't seem to work. And of course, if you have acid reflux, that pathway is then disrupted, because if your larynx is bathed in acid all the time, then you lose that normal sensation, and therefore the brain doesn't know how much tone is needed. Yeah, so it's that sort of sensory motor integration that doesn't seem to work. Yeah, and reflux and laryngomalacia coexist, and that may be because reflux reduces the normal sensation, or maybe you have airway obstruction and therefore you get reflux, or maybe both. Yeah. Typically, it's an inspiratory stridor that starts at a few weeks or a few days of age. You can diagnose in a flexiscope, but beware of synchronous pathology. So I think most children with laryngomalacia don't come anywhere near secondary care because they just see the GP and the GP reassures them. And probably a number go to see paediatricians and paediatricians reassure them. So I think what we see in ENT is probably the tip of the iceberg, because I think there's a lot of it out there that never ever makes it anywhere near an ENT surgeon. Yeah, because it's just very common, and you know, paediatricians and probably lots of GPs likewise are really good at managing it. And normally children just grow out of it, so you don't need to do anything. Or maybe they've got bad reflux and you manage their reflux. But if a child's got blue episodes, if they've got increased work of breathing, if they're struggling to breathe and feed, you know, if they've got really sort of bad recession or the parents are worried, then you can offer them surgery. The first thing would be you do a full diagnostic airway endoscopy to check it is just laryngomalacia, and then you can do supraglottoplasty. And majority of the time, you know, that is curative for most children. The ones in the neonatal unit, much more difficult, because to my mind, those ones, it's much more common for them not to be better after supraglottoplasty and me having to then operate on them twice. And then normally they're better twice. And I think even on 1 or 2 occasions, even we've operated on 3 times and then they've been better. Yeah, but your box standard laryngomalacia probably doesn't come anywhere near an ENT surgeon. And if it does, it's usually conservative. And if you do operate on them, it's usually just a one-off. Any questions sort of about that vocal cord palsy or tongue base obstruction or laryngomalacia before we move on?
Am I the only one gonna ask you?
Go on then. Yeah.
So again, for the vocal cord palsy, do you do gastrostomy for those children, or how do you manage the feeding with the vocal cord palsy?
So some of them are not too bad and they can feed themselves and then don't do anything. Yeah, they just feed orally with speech and language therapy support. So they would be the very mildly affected one. Yeah. Then if you have, then the next kind of thing would be nasogastric tube feeding. And I probably would stick with that because chances are they're going to get better before too long. If the baby can't feed at all, I'd always be tempted to do a trachea, because, you know, because then you've got, okay, they're going to end up with some kind, they either have a long-term feeding tube or they have a long-term breathing tube. And to my mind, it seems nonsense to do a gastrostomy to avoid a tracheostomy, because they've ended up with a tube, haven't they? So I'd probably rather do a tracheostomy, and that means that they can then feed orally. Because the problem is, if you do a gastrostomy because they're too out of breath to feed, you've created a lifetime of aversion and feeding difficulties, because then the feeding never establishes. So actually, I think it's going to be a reasonable duration and they can't feed at all, I probably would not do a gastrostomy. I probably would do a tracheostomy for them. And that does sometimes happens in that difficult category where they're not bad enough to need an immediate airway intervention, but they still can't feed. So for me, inability to feed at all and no realistic prospect of feeding improving and having some kind of feeding at home, I probably would be tempted to just go for a tracheostomy rather than gastrostomy. So yeah, I don't think that we've often done gastrostomies. I think we probably would just do a tracheostomy instead. And then, of course, they can then feed, yeah.
Hi, and also Mr. Said is here, so want to ask you some questions.
Sure.
I have 2 more questions for you.
I just want to ask you about when you decide about doing surgery for laryngomalacia, what will be the indications, and if you could explain the techniques, your technique in doing the surgery. I know the surgery I worked for you as a registrar, but I would like to share your experience with the team, because it usually asked in the exams, and I think it is good technique. Thank you.
Yeah. So I think in terms of indication for surgery, it really would be severity. So if you have a child whose parents say the child's going blue, the child's stopping breathing, the chest and ribs are getting sucked in, the child can't feed, the child's not growing, they're not able to take bottles, or I've done a sleep study and found they've got sort of really bad sleep apnea, they for me would be kind of indications for surgery. The problem is you have lots of children that are kind of a bit in the middle. Yeah, you know, they don't stop breathing and there's not an awful video and they can get some feeds into them. And then sort of they're more difficult. And the really kind of useful determining factor for me in the middle, sleep studies can be helpful for the children that are not obvious in either, yes, they need something, or no, they don't need any category. So sleep studies can be useful. But the other thing also would be, how long does it take them to feed? Because what you sometimes find is that yes, they are growing and yes, they are feeding, but it's, it's families, it takes an hour to feed the baby, sort of, instead of 10 minutes or so. And then the whole family ends up being exhausted because the baby doesn't have enough breath. And, then sort of they spend 1 hour in 4 trying to feed this baby. And then that becomes exhausting for the child as well as the family. So for those intermediate ones, sleep studies would be useful for me. And then also, how long does it take to feed the baby? And then what impact that has. Yeah, so they're kind of for the intermediate ones. But, often it's shared decision making. And, and a good question is that I would ask is, how worried are you about the little ones? And I discuss that with the families, and often it is that kind of shared decision making. I think in terms of techniques, there's probably, okay, so the first thing would be, cold still versus laser power techniques. I think most of us in UK would probably do cold still techniques. The problem with laser is it causes airway fire and it's a faff to set up, and I don't really think that the laser adds very much over cold still techniques. So I think most people in UK do cold still technique, which is what I do. And you put them into suspension. You use like sort of a baby version of Lindholm laryngoscope that you might use in an adult, so supraglottic scope. And then normally I think of it as where the problems are, and you try and deal with the problems. And if typically would be, is it short area epiglottic folds, or is it that prolapsing supraretinoid tissue? And occasionally the whole epiglottis falls backwards, which is a much more difficult thing altogether. And then typically, you've got two philosophies. So there's a philosophy which is, I'm going to do everything that I can because I don't ever want this child in my theatre again. Or there's the other extreme of the philosophy, which is I'm going to do the minimum necessary and the minimum thing that I think is safe and reasonable to do, and I don't really mind if I kind of see the child in my clinic if I have to operate again. Yeah. So typically for me, I'm probably in the former category, which is that if I have somebody in theatre, I want to do everything I can in that procedure to avoid the child coming back. So for me, typically I will divide both area epiglottic folds, and if there is redundant supraretinoid mucosa, I will remove it on one side, not on both, because if you remove both prolapsing supraretinoid mucosa, there's a danger you're not going to have enough mucosa at the back, and then you kind of get that posterior supraglottic stenosis. Yeah, so you can divide both area epiglottic folds and remove one supraretinoid tissue. Oh, I've got balloons coming up now. How exciting! Okay, so was that the hand gestures? Is that great? No, I can't make it to go again. So typically, yeah, I would remove supraretinoid tissue just on one side. I mean, in theory, you can on both, as long as you preserve a bridge of mucosa, but you'd have to really know what you were doing. Some people will typically just divide the area epiglottic folds, and they would say that that's enough. And and I don't know what the right answer is. For me, if I see mucosa that prolapses in and out of the airway, then typically I will remove it on one side, and hopefully that's going to be enough that I don't have to see the child again. In some of the little ones, the ones on neonatal unit, the kind of the 2-3-week-old ones that we do also see, often they're really, really difficult. And sometimes I just accept that I try and do what I can. It's really difficult to remove the supraretinoid mucosa. So often in those, I'll just divide the area epiglottic folds, and I'll say to the family, look, it was really difficult because the baby's small, or they're desaturated. And I say, okay, that's what we've done. If we have to look again, then we're going to have to look again. So sometimes I accept that I perhaps haven't done the best technical procedure because they're desaturating, or because they're small, or because access is difficult. And then I just say to the family, I might need to do a bit more next time. And also I typically do it without a tube, so it's quite easy to remove the supraretinoid tissue if you don't have a tube in, but you can also do supraglottoplasty with the baby intubated. But if the baby is intubated, then the access to the area epiglottic folds becomes much easier because the larynx is moved down, but the access to the supraretinoid tissue becomes much more difficult. So normally I do them without a tube, and I can access that posterior tissue. But if you have them intubated, then dividing the AE folds is easy. but removing the suprarytenoid tissue is difficult. So normally I don't have them intubated. I divide area epiglottic folds and I remove suprarytenoid tissue if it's floppy on one side. But other people will have them intubated and they're just going to divide the A folds. And sometimes I have to have them intubated, and then I do what I think I can, and I accept I might have to bring them back in 3 weeks. Does that answer the question?
So we have like
it does answer the question, and again I just have another good question actually, which will be helpful for the colleagues going for the exam.
We will have like 15 minutes left. So
Yeah,
very quick,
that's
please.
fine.
And we have
If there is a
more
time,
questions.
if you could explain at one point of the talk steps from A to Z, how to do tracheostomy in children, because it is not done in all hospitals, and sometimes people will be asked. Usually, lots of people have never seen it, so it will be quite helpful as well. Thank you.
Yeah.
And Matt, before I forget, next airway course will be in December. We will do some hands-on. We already have some cheap ranks to do cricotracheotomy, but next time we will get some neck rabbit to do tracheostomy as a pediatric. Are you happy to join us as well, if you don't mind?
Yes, I'll have to look at the dates, but yes, in theory.
Yeah, I'll send it to you as well. Sorry for this.
Okay, so I'm aiming to be done by 15:15. Yeah, is that what I'm aiming for? Question.
I don't mind to stay, but just we have people that have ended their work as well.
That's right. Yeah. So okay, right. So I need to speed up. Okay. Yeah. So when something that starts when you're a few weeks or a few months of old, subglottic hemangioma, all of you will know sort of the pathology of infantile hemangioma, and propranolol has completely revolutionized how we treat with these. Yeah. The other sort of thing then, moving on to airway obstruction in a child, again, the differential diagnosis here is wide. Sort of these are the kind of 4 common conditions. For croup, ENT, we don't get involved in croup unless it's really bad and somebody's going to go to ITU, or it's recurrent croup, and then people ask, do they have subglottic stenosis? But croup, typically 6 months to 3 years, they have a bit of a NERT, a barking cough, gradual onset, and swallowing is fine. Epiglottitis, I don't think that I've seen epiglottitis in a child in UK, but probably 2 to 6, very sudden toxic drooling and muffled stridor. Tracheitis is the thing that I've seen that presents as really sort of very severe. So they're very, very sort of toxic. They struggle to swallow, but perhaps a little bit more gradual than classic epiglottitis might be. So actually, whenever I've taken somebody to theatre for query epiglottitis, what I probably found is either bad tracheitis or croup, or a combination of those. And tracheitis, they're really, really sick. And then foreign body 1 to 3, sort of with a fairly sudden history, and often they're going to have wheeziness rather than stridor or stertor. For epiglottitis, you all know it's caused by Haemophilus influenza type B. There's the classic tripod position. Don't scope them, don't poke and prod them, just take them to theatre and secure the airway and give them antibiotics. I've said all of that. Okay, so inhaled foreign body. So you've got 3 things that determine what you do with them. You got history, examination, and chest X-ray. And standard teaching would be if you got 2 out of the 3 that are abnormal, you ought to be looking. Okay, so if you got a history that suggests a foreign body or examinations abnormal, normally I ask pediatricians to tell me what they think, because they listen to baby's chest much more often than I do, or to toddler's chest. But if you have 2 out of the 3 that are abnormal, then you ought to be looking. And the chest X-ray may be normal, or it may be hyperinflated or hypoinflated. You might get collapse consolidation, so it could be any one of a number of different things on a chest X-ray. I have to say I'm probably increasingly also erring to, even if one of those things suggests a foreign body, having a look, and that's probably because I've learned the hard way of sort of something that suggested there might be a problem that led to issues. So definitely, if 2 out of the 3 are abnormal, you definitely need to be looking. But actually, even if one thing is abnormal, you probably need to have a really good reason why you would not be doing an airway endoscopy. Yeah. The issue with this is it's not particularly urgent. Yeah. So it doesn't need to be done at 2 o'clock in the morning. Say you've got a well child and they've got really good history and they're a well child. You don't need to do that at 2 o'clock in the morning. It can be done tomorrow. Or if you don't do airway endoscopy, you can refer them to a tertiary centre, and the tertiary centre can do the following day. Yeah. So it's even if it's one, just sort of think about it. Yeah. Any questions about foreign bodies before I move on? Okay, so post-extubation stridor, again, you know, that's the other thing that that you're going to get called wherever you are, whether that's in neonatal unit or whether it's in recovery, when, you know, child's had surgery in your hospital for something else that's unrelated, and then they're extubated, and then they have stridor. And the pathology really there that you're wondering about is subglottic stenosis, yeah? And acquired subglottic stenosis is majority of all subglottic stenosis. Incidence has dramatically reduced because anaesthetists, neonatologists, PICU doctors are just much better at managing the airway, yeah? So the incidence is much reduced. The cricoid and the subglottis is the only complete ring. The mucosa is very friable and delicate, and it's the narrowest point of the pediatric airway. In an adult, it's the glottis. In a child, the cricoid, the subglottis, is the narrowest part of the airway. The Cotton-Meyer grading describes the grading of airway obstruction, and it's based on cross-sectional area, yeah? So not on millimeters, cross-sectional area, and cross-sectional area is pi r squared, yeah? So that's your cross-sectional area, pi r squared, yeah? So it's cross-sectional area reduction, grade 1, 2, 3, 4, and you compare it with an age-appropriate ET tube. So if a 3-year-old child, you know what size tube a 3-year-old child would take, but actually they only take this tube. And the ET tube is named by the inner diameter, yeah? So to calculate it, you need to go let's say you've got a size 3 ET tube, inner diameter, then you look on the packet to see what the outer diameter is, so that's your diameter. So, but the cross-sectional area is pi r squared, so you know what the packet says, this is diameter, then you divide that by half to get the radius, and then cross-sectional area is pi r squared, yeah, and that's how you get to what it should be versus what it is. Or you can just look at tables in a formula, yeah, but that's how you get to it. ET tube, inner diameter, then you look on the packet, outer diameter, pi r squared, that's a cross-sectional area, and then you can compare what it is versus what it should be. And, you know, there's a range of different types of subglottic stenosis. They all kind of look different. If you have early subglottic stenosis, often the subglottic edema, and the more you poke and prod, and the worse it's going to be. So if a child's failed extubation or they've had stridor, then if you've had to re-intubate them, don't keep poking and prod them, yeah? So give them some steroids, give them antibiotics if need be. Adrenaline nebs can be useful, and CPAP can be useful as well. And if you are going to extubate them again, extubate them when they're well, yeah? Because if they have an oxygen requirement and they've got a respiratory infection, the last thing that you want is to try and extubate them when they're ill. And a nose tube is often better than an oral tube because it tends to move less and is better tolerated. And then early subglottic stenosis, treat their reflux, give them steroids, CPAP. Subglottic cysts we often see, yeah, so this often happens after a child's been intubated, and you marsupialize them, so you can remove those, you can remove granulation tissue, you can do balloon dilatation, and then also, you know, tracheostomy, LTRs, or cricoid split as well. They kind of would be the advanced thing. But typically it's that conservative management, optimize them, CPAP, adrenaline nebs, and endoscopic airway optimization of any granulation tissue or any subglottic cysts. And actually I think that's kind of my penultimate slide. The last thing that I want to briefly talk about, and maybe that's again a bit more of a discussion, is about do you transfer and don't you transfer? And maybe we can pick some of that in the discussion, but I'll kind of wrap up because I think that's really is my last slide. So for me, the decision about whether you transfer or not depends on 3 things. So it's your skills, but not just your skills. I've got balloons again. So not just your skills. Can I do that again? No, not just your. Oh, no. Okay. So it's not just your skills. It's also the skills of the anaesthetist and the theatre team and the kid that you have and your institutional backup and your institutional support and the child and their pathology. Yeah. So it's got to be the 3 of those things have to all align for you to go ahead. So, you know, as surgeons, you probably have the kind of skills that are needed to do all of that, but your anaesthetist might not, and you might not give PICU backup, or the child might be too complex to be managed at your hospital or at my hospital. Yeah, because I sort of transfer children elsewhere too. So for me, you know, to transfer or not to transfer, it's a mixture of the 3 different things. Okay, that's it. I've stopped sharing that and get sort of that slide. So I could see some questions. So where should
There's a lot.
Yeah.
So we can start from, sorry for the name, but there is, what is your protocol to rule out? I think so. This is associated anomaly because ASO, with the laryngomalacia. So like any other bronchotracheal anomalies, vascular, non-vascular, all of those. Do you do scans? We don't scan when you scan those children?
Yeah. So if you have a child that has stridor that started when they were a few days or a few weeks of age, and it is an otherwise healthy child that looks otherwise normal, that is noisy but thriving and feeding okay and doesn't need anything doing, I wouldn't do anything else. Okay. So, you know, if I have a child that has something unusual in the history, then I'm going to scope them. So let's say somebody that has let's say they've got biphasic stridor, or I do flexiscope in clinic and I don't see any laryngomalacia, or it's a child that's got something that suggests a syndromic, they've got other abnormalities, chromosomal abnormalities, for example. I'm going to scope that child and involve pediatricians, aren't I? And equally, if a child is struggling, if it looks like an otherwise healthy child, but they're struggling with the airway, I'm going to scope them and probably do a supraglottoplasty. Yeah. So that's kind of how I would think of it. Yeah. So it's if it's a well child that's not struggling with standard laryngomalacia, I don't do anything. But if it's an otherwise child that has other health problems, I'm going to scope them and involve pediatricians. Or if it's a child that's struggling, I'm going to scope them anyway. Yeah. So that's kind of how I would think about investigations. Wouldn't normally scan them unless I identify a particular thing. You know, I wouldn't scan on a just in case. You know, what am I asking for? And of course, if I see pulsatile tracheomalacia, you know, then I might do CT angio, for example. Yeah? Or if I see a small mandible, then, you know, I might do sort of CT mandible if I think they're going to have mandibular distraction. And usually then involve pediatricians as well. But in practice, they're otherwise well child that's thriving, in which case you do nothing, or it's a not a otherwise well child or not a thriving child, in which case I'm going to scope them anyway under general anesthetic.
The second question is, when do you decide to start by tracheostomy as early intervention? So what is the indication to do a trache for those airway that there's no other choice to wait and see?
You mean, is this for vocal cord palsy?
Yes, that was mainly for the early stridor children, the early age.
So I mean, the ones that are easy are the ones that can't get off a ventilator. Yeah, so you know they're easy because you try and extubate them, and the child then just ends up having to be reintubated, and you know they've got nowhere else to go. Yeah, and you're just going to do a tracheostomy. I mean, it won't be laryngomalacia, but let's say they've got sort of bad micrognathia, for example, or they've got bad vocal cord palsy or some congenital thing. You know, if they can't get extubated, then you're probably looking at tracheostomy. For micrognathia, you might want to think mandibular distraction, actually, sort of just sort of putting that out there. And then, you know, the ones that are kind of in the middle, they're really, really difficult as to what you do. And, you know, for me, the sleep studies can then be useful, you know, how bad the sleep study is, and then also feeding would be the other thing also useful, because, you know, if a child isn't able to feed, like we were talking earlier about, they're then nasogastrically fed, or you're contemplating a PEG, are you better off just doing a tracheostomy rather than sending them home with a tube? And very much a kind of multidisciplinary setting, yeah. But the ones that are not obvious, really, really difficult, yeah, and often lots of multidisciplinary discussions, respiratory, sleep studies, etc. So they're difficult in a multidisciplinary discussion. As I say, the ones that are intubated, they're easier because, you know, what else are you going to do?
The next question is, this is a bit of a long question, but we tried to do it short. Is about the explanation, the technique of a foreign body remover via ventilation bronchoscope. We used to do it in the course, and I think it's a big one. So, but you can say in a very, very short what you preferred. Yeah.
So normally I would start with a Hopkins rod lens telescope and an anesthetic laryngoscope, and on occasions you find that the airway is very dry and pristine with not particularly much pus, and you find something that is easy to grab, in which case I will continue with my anesthetic laryngoscope and either a tube in the hand, a tube in the nose, or high flow, depending on what the anaesthetist want, and I will then go to the optical grasping forceps. And you know, you've got the peanut grabbers, which are the atraumatic ones, you've got ones that have teeth on the end, and you've got ones that are serrated all the way, so there's different endings to them. Yeah, so I would choose the tip of the forceps depending on what the foreign body is. Yeah, and And if the airway looks clean and there's no pus, then I will just use just optical grasping forceps. More often than not, by the time that you get there, there's lots of muckiness and secretions, and you are needing to suction. So then I would go for the Storz ventilating bronchoscope. And sometimes the child doesn't tolerate anesthetic very well, and you then have to ventilate them through the bronchoscope. The advantage with the bronchoscope is that you can put the suction down, you can suction the secretion. So suction goes in, you suction the secretion, then you can put instruments, suck secretion, put instruments, sub secretion, put instruments. You can put a feeding tube down, you could squirt a bit of adrenaline down if you've got some bleeding or granulation tissue. So it's that ability to suck instrument, that is useful. And then typically, again, we will do optical grasping forceps through the ventilating bronchoscope. Remember, the optical grasping forceps don't fit through the bridge, so you have to take the bridge off because the forceps don't fit through it. And in my view, it takes 3 surgeons to do a foreign body bronchoscopy. Okay, so I think people underestimate how many pairs of hands you need to do that. Yeah, because the way that I like to do it is one person has the bronchoscope, one person has the optical grasping forceps, the third person has the suction. Yeah, or you can substitute your scrub nurse and tell the scrub nurse to put the suction in and out. But the ideal thing is you have 3 surgeons, because one person controls the bronchoscope and directs it where it is and just calls the airway. Second person puts the optical grasping forceps in and out. Third person then operates the suction. Yeah, and then sort of once you grab it, you've then got to decide what you do, and then typically everything comes out. So the bronchoscope and the optical grasping forceps come out at the same time. The key thing is that you're pulling out when you get to the vocal cords. You need to change the direction that way. Yeah, so normally you pull back. When you get to the cords, you then need to change and then go upwards, because the angle changes in that direction, and you have to tell the anaesthetist that everything is coming out. The other kind of tips also have been, sometimes you can use an angio balloon that can go beyond the foreign body, and you can inflate the balloon and you can bring that down. You can pull that towards you. Flexiscope can sometimes be useful also, but of course you can't do anything with a flexiscope. But sometimes there's been things that you can try and suction, or you can at least remove the mucosa. And the other thing sometimes is we've done it several times, because if there's been lots of edema and lots of granulation tissue, we said, okay, we can't get it out today. We're going to put you on the ward, have some antibiotics and steroids for a week, and we're going to have a look again in a week's time. So I've had to do that as well. I know that's a really long answer, because I think there's so many different ways that you can approach it, and it's not at all easy. Not easy. Technically, it's difficult.
Thank you. There's a few more questions, but we don't have much time. But it's okay. We impacted foreign body in trachea. I think so that you cannot take it out. You answered that question about leaving the child with antibiotics in the ward and come back again.
If in the trachea, it's not going to be difficult to remove, yeah, because it's normally going to be easy to access. So the child's probably going to be dead. Yeah, I mean, it depends on the size of the foreign body. Yeah, but if they have a massive foreign body in the trachea, then the child's going to die when it happens. If they kind of have something that, maybe a sliver or something that is impaled on the trachea, that normally they're not particularly difficult. The ones that are difficult, the ones that are a long way down, they've been there for a fortnight, there's lots of granulation and bleeding. They're the difficult ones. Yeah, the tracheal ones are actually normally not that difficult to get out, because they're easy to access.
But for myself, the very strange foreign body for myself is back home was a lady. It wasn't a lady like 12 years old. She wore hijab. She put the pins, and she inhaled the pins, and unfortunately it gone through the whole trachea, esophagus down. I don't know how it comes, but it was impacting that way toward the spine. Yeah, which is really was very strange, very difficult one to be taken out. So sometimes, it can be.
Yeah, I mean they can be tricky. Absolutely, yeah, you're right. And sometimes the pins. I've also seen the pins go very lateral, and so you couldn't get them out. Yeah, or you could use a flexibronch, and sometimes you can grab it with a flexibronch. Like with the OGD biopsy forceps, for example, and you can try and grab them that way. But sometimes it's gone so far peripheral that you've ended up involving the thoracic team, and they've ended up having to remove a lung segment as well. So it can be. Yeah.
Okay, thank you for everything. So the question. Sorry, there's a lot of questions now. Okay, how many episodes of documents, treatment episodes of group make you decide to list the patient? Sorry, there's just a lot of questions there.
Oh, yeah.
To,
You know,
for diagnostic.
That's a great question, and I don't have an. So my answer is, when people ask me, I have a look. And I know that's a cop-out. And the reason why I say that is because I don't manage croup. I don't know what's normal croup. If the pediatricians think that this is abnormal, you know, then I have a look. Usually, whenever I've had a look in an otherwise healthy child, the chances of me finding anything is vanishingly rare. Okay, so an otherwise healthy child with episodes of croup, or almost always I don't find anything structural. So if I have an otherwise healthy child with croup, our hospital, they go to respiratory rather than ENT. Yeah, so they go to respiratory first, they work them up. If the child's not any better, then we do an LTB and a flexibronch. Yeah, and if the LTB is normal, then they do some washings and lavage, and then they follow them up. And on the off chance that I find something, then I take them. So in an otherwise healthy child, typically we would actually do both together. If the previous intubation they've got abnormalities, then, you know, yes, you are much more likely to find something. I think, you know, my guess would be sort of 3 episodes in a year, something like that. Yeah, but I'm not aware that there is a definition of recurrent croup. And as I say, my attitude is, if pediatricians have said this is unusual, then I have a look. Yeah.
Just before we finish, just everyone need to put the emails in the comments so I can send them the CD points. I'd have 1 CD point from the Royal College of Edinburgh. So just to get your certificate, please do not forget to put your email there. And the last question, I think so, can ask about the how do you suspect that there is a vascular malformation causing stridor, and the psychological support to the family?
So I mean, vascular malformation, I suppose if you're thinking about hemangioma, you know, they're associated with other hemangiomas in the beard distribution. So, you know, if you see one in the beard distribution, I might be thinking, okay, hemangioma is much more likely as a vascular tumor rather than malformation. But of course, you can get them without any external thing. So I suppose it would be, you know, it would be on the history. If it's a typical history of inspiratory stridor in a baby that started when they were a few days of age, then, and I've had a look, then that's laryngomalacia. Anything other than that, you know, I'm going to end up having a look under a general anaesthetic. Yeah, so I'm not sure, other than the fact that they've got something else that suggests they might have it. I don't think that I've got anything else particular in the history, other than it's not your bog standard laryngomalacia, which is really common. And in terms of the psychological thing, I'm really lucky that I've got a really good specialist nurse. So I don't think, you know, where I work, we don't have any particular psychological support, but you know, having a nurse who has time with the patients, much more than I have, and expertise actually, you know, that's really useful. So whether that's a dedicated nurse that you work with, you know, or whether it's one of the ward nurses or one of the usual clinic nurses that is able to take time, you know, identifying somebody that has more time than you have to spend with the family, you know, that is just invaluable.
That's great. Thank you. Thanks, Matt. So as we usually do at the end of the year in December, I'll send you the date. Already we plan it. We used to do pediatric audit bronchoscopes, hands-on. We do hands-on cricothyroidotomy, cricothyroid needle, ventilation, intubation. So it's a whole emergency course. Yeah, Wendy, you know, Wendy, my partner now in his education, he's doing great, to be honest. Last time he's done a lot of effort. So if you don't mind to share us as well with your experience, especially the question about the tracheostomy. So we plan to do this pediatric tracheostomy for you. It would be great if you can do something with us.
Yeah. You want my new colleague Shanine, because she's better than I am.
No, it's okay. You both.
Have,
it's just you're part of your dinner. This is part of the dinnery and part of the education, and
we can have both of us. Yeah.
Yeah, sure. That you're welcome for sure, and it's your place. Lincoln is part of Nottingham. Nottingham is part of Lincoln.
Same medical school.
Yes, same medical school as well. Yeah. So thank you everyone, and just be sure that you put your email for getting your certificate. Thanks again, Matt. Thank you.
Everyone.
Thanks. Bye.
Bye bye.